Okay, atrial flutter is going to have an atrial heart rate of 250 to 300. P wave will be the sawtooth, varying, non measurable PR. You do have a QRS, and again, it's a sawtooth pattern associated with CAD, hypertension, mitral valve disease, pulmonary emboli, cardiomyopathy, hyperthyroidism, or drugs such as DIG or quinidine. Patients catheter ablation, so removing that bad part of the heart via cardiac cath is the number one treatment. However, drug-wise, they'll probably also be on a drug thinner or blood thinner, warfarin, for an INR of 2 to 3. Bleeding precaution and potassium foods should be discussed. For chemical cardioversion, they might have amiodarone, beta blockers, or calcium channel blockers. Okay, looking at AFib, you're going to have an atrial heart rate of 350 to 600. With controlled, we'll have a ventricular heart rate of less than 100 or rapid response greater than 100. A febrile or chaotic P wave, non-measurable PR, QRS is normal. Atrial AFib is like the most common dysrhythmia. It's atrium firing in multiple spots. It's related to CAD, valvular diseases, cardiomyopathy, hypertensive heart diseases, heart failure, pericarditis, thyrotoxicosis, alcohol, caffeine, electrolytes, stress, and cardiac surgery. So you are going to treat this again with that. Definitely blood thinners are going to be a big thing here. Beta blockers for rate control, as well as calcium channel blockers. Amiodarone will be on here as well with AFib. And you are going to want to do conversion if these things are not working, either by radiocath or chemically with amiodarone. And if you're doing electrical and they've been in AFib for more than 48 hours, you need to do a TEE to assess for clots. And if they are, they should be on anticoagulation 3 to 4 weeks before and several weeks after this. Okay, PAC, preatrial contraction. This will depend on the underlying rhythm as far as rate. It is irregular, and you have a premature or distorted QR or P waves. This is ectopic focus, so from the atrium, and it's cause of emotional stress, caffeine, tobacco, alcohol, hypoxia, electrolytes, COPD, valvular disease. It can be an isolated event in healthy people and is not a cause for concern. However, if you're sick, it can be a sign of an underlying heart disease or dysrhythmia. Treatment, a lot of times they won't treat this, but you might also use beta blockers to reduce the amount of PACs that show up, or just reduce stimulants and control emotional activity. Okay, so here we have got PVC, premature ventricular contraction. And so you can have any heart rate with this. You're going to have an irregular P wave. Might be lost in the QRS, a non-measurable PR, and the wide distorted QRS, so greater than 0.12. T wave is typically wide. These can be multifocal, unifocal. So multifocal, they're all different shape. Unifocal, they're the same. If they're different rhythms, you don't have to worry about, but there's 3 in a row. That is VTAC. This is an early QRS is basically the sign of this, and it's followed by a pause typically. It's typically associated with stimulants like caffeine, alcohol, nicotine, epinephrine, isopropanol, or digitalis. electrolytes, hypoxia, fever, exercise, emotional stress. The prognosis is okay for healthy people, but heart disease, it's decreased cardiac output, therefore angina, heart failure, depending on frequency. And what you really want to check is their physiological response. And so PVC, check their apical radial pulse for a pulse deficit. And then you want to assess their hemodynamic stability, especially if they need drug therapy. So always treat the cause. Again, if their oxygen is low, they're hypoxic, give them oxygen. They're going to have beta blockers as well as procainamide and amiridone. All right, SVT or PSVT, this is atrial rate of 150 to 200 and regular or slightly irregular. The P wave may be hidden in the T wave, and it is ectopic focus anywhere above the ventricles. Proximal transit, so it may be followed by a brief period of asystole. It can be sustained, which is SVT, but usually it happens in runs. So it's caused by emotional stress, overexertion, deep inspiration, stimulants like caffeine and tobacco, rheumatic heart disease, detox, coronary artery disease, or cor pulmonale. Basically, prolonged episodes greater than 180 will cause a decrease in cardiac output because of reduced SVR. Hypotension is a problem. So what you're going to be looking at here with SVT, you might also have palpitations, dyspnea, and angina. So vagal stimulation, massage, or coughing. Number one treatment is IV adenosine. You might use amiodarone, beta blockers, calcium channel blockers. If they are hemodynamically unstable, you want to cardiovert them, synchronize cardiovert them. And if it returns, they might look at the ablation after an EPS to see if there's any clots before they just let them go. All right, getting into VTAC. VTAC, you have a ventricle heart rate of 150 to 200. P-wave may appear. PR is not measurable. QRS is typically wide and distorted. It's just a mess. So you getting into some of the basics. It's an ectopic focus. Fire repeatedly, the ventricle becomes the pacemaker. If it is sustained, it's more than 30 seconds. Non-sustained is less than 30 seconds. And then stable means they have a pulse, unstable, no pulse. It's associated with MI, coronary artery disease, CNS disorders, electrolytes, cardiomyopathy, mitral valve prolapse, and drug toxicity. Unstable, they can become hypotensive, pulmonary edema, low brain perfusion, cardio arrest, and you need to treat them as soon as possible, even if it corrects itself prophylactically, or else it could reoccur or even come back as VFib. So if they're stable, you're going to be doing like IV amiodarone or IV magnesium, and possibly pacing them, and then you want to discontinue any QT long drugs and synchrovert them if the drugs don't work. If they're unstable, you need to start CPR immediately and then rapid defibrillation. Use vasopressors like epinephrine, and then an dysrhythmic like amiodarone. If the defibrillation doesn't work, also you would do defib again. Okay, so VFib is going to be just a mess. The R wave or the PR is just chaotic. Nothing can be measured. So multiple firing in the ventricle. There's no cardiac output. So it's associated with acute MIs, myocardial ischemia, heart failure, cardiomyopathy, during cardiac pacing, cardiac cath, post-thrombosis therapy, shock, hyperkalemia, hypoxia, or acid base or drug use. So significance is the patient is unresponsive and pulseless. Apneic, it's a very lethal. And you're going to do CPR right away and defib them with no delay. You might use vasopressors like epinephrine. All right, asystole, basically flatlining. Patient is unresponsive and pulseless, associated with advanced heart disease, severe conduction dysrhythmias, heart failure, end stage. So you're going to do CPR and then life-saving measures such as intubation or epivasopressin, using that, and SIV therapy, and then defibrillation as well. Very poor prognosis. Okay, pulseless electrical activity. It's the most common dysrhythmia seen after defib. It's a poor prognosis unless it's quickly identified and fixed. Can be related to hypovolemia, hypoxia, metabolic acidosis, hyperkalemia, hypoglycemia, hypothermia, drug overdose, tamponade, thrombosis, MI or pleural embolus, and tension pneumothorax and trauma. Basically, if they're pulseless, do CPR. Be prepared to IV, epi, and intubate, as well as defib, and then fix whatever it is that's going wrong is critical. Okay, then we have sudden cardiac death. Basically, the cause is abrupt disruption of cardiac function and loss of cardiac output and cerebral blood flow, so low ejection fraction. Left ventricular dysfunction and ejection fraction of like 30%. Ventricle dystrophy after an MI, cardiomyopathy, diabetes, hypertension, high lipids, and if you've had a previous sudden death, cardiac death, and survived it. Management, you need to diagnostic workup similar to coronary or ACS. Signal average EKG, you need to do EPS for any sort of clots, possibly, or you will do an ICD, so implant the cardio defibrillator, possible role changes and driving restrictions, possible changing your occupation. Most people die during this. This is what young, healthy people die of. So it's usually suddenly within 1 hour of onset of acute symptoms like angina and palpitations, almost always from a cardiac cause, and it's the most sudden cardiac death is from ventricle dysrhythmias like VTAC and VFib. Okay, then we have got our heart blocks. So we have a first degree heart block, which is basically going to be an elongated PR. No treatment, you just monitor this. And then you've got a second degree type 1 or the Winkelbach. And basically the PR gets longer and longer and longer until finally one drops. If there's symptoms, treat this with atropine, and then possibly a temporary pacer. If they're asymptomatic, you really need to monitor them with a temporary pacer nearby. If it's a type 2 block, the Mobitz 2, basically you're going to have the same interval of P, but then you'll have a QRS that just disappears. And you need a temporary pacer for that. And then the third degree is the P's and Q's don't agree, so they're consistently ventricular rate, consistent atrial rate, but then they have nothing to do with each other, so you can't really measure the PR. You're going to need to do as soon as possible, this is kind of an emergency situation, you need a trans-Q temporary pacer until a permanent pacer can be put in place, and you might need atropine, dopamine, or epinephrine. So if you look up the way, just a couple quick recaps. You've got your normal sinus rhythm, your sinus tachycardia, just faster, beta blockers, calcium channel blockers, adenosine. If it's unstable cardiovert, sinus brady, do your atropine with your pacing if you need. PVCs has the wide QRS, and rocainamide and amiodarone, as well as beta blockers, a flutter, you have those little sawtooths, amiridone and the ablation, as well as warfarin and the INR, a fib, you've got just those fibule waves, and you want a beta block, calcium channel block, and maybe convert with the coagulation. You'll probably be on coagulation forever, but also 3 to 4 weeks before and several weeks after if it's a fib longer than 48 hours. Don't worry about STEMI. STV, the P's and the T, and you typically have runs. You're going to want IV adenosine, beta blockers, amiodarone. If they're hemodynamically unstable, you have got to cardiovert them, and ablation if it returns. VTAC, amiridone, unstable, rapid defib after CPR. And then if they're VFib, CPR, defib. And then one more quick look at our drugs here. Atropine, Brady second, third degree assist. So again, you need to do the pacers first, but you might also use the atropine. Adenosine, sinus tac, and SVT. Amiodarone, potassium channel. So you've got this for your A flutter, PVC, SVT, and stable VTAC. Beta blockers and calcium channel blockers for just PACs are just beta blockers, but then both of them for sinus tac, PVC, A flutter, AFib, SVT, anticoagulants for AFib and A flutter. As far as procedures, cardiovert anybody who is unstable SVT, unsuccessful beta blocker, or for AFib, or unstable sinus tac. You want a defib, the VFib, and unstable VT, also asystole on here. Ablation for A flutter and the return of SVT. Pacers for the heart blocks, especially number 2 type 1 with symptoms, or number 2 type 2, or sinus Brady. Permanent pacer always for type 3.